Dear friends, welcome you all to the 11th training program of Ecmo Society of India. In the next few days, we will be discussing about how we do Ecmo, which patients are indicated for Ecmo, what are the complications, and how we manage them. We discuss Ecmo today in the backdrop of a pandemic where we have seen patients dying because of lack of oxygen. Hence, discussing Ecmo and spreading its utility is more important today than it was ever before. Throughout the world, the ECMO utility has increased. More number of centers are doing ECMO in more number of patients, as well as the outcome of ECMO has increased, mainly because of the better understanding of the pathophysiology, as well as because we have a better equipment. Even in India, the number of centers performing ECMO has increased. If we go back 70 years before the polio epidemic, ventilator was not frequent in the ICU. It was the polio epidemic of 1952 which saw the advent of the ventilator. Though ECMO has been there since the 70s, yet it took the H1N1 flu of 2009 to establish the large-scale utility of ECMO internationally. Yet India lagged behind. It was only during the 2021 COVID-19 epidemic that we are more familiar with the ECMO, and it is generally well accepted by critical care people throughout the country. Many centers have come up. The old centers have increased their capacity because of the increased demand. I'll just give you an example of what we have done in our center. If we started off with a single machine in 2014, it didn't got the second machine in 2018. During the first phase of the pandemic, we went up on the capacity to 14 ECMO machines. And during the second pandemic, we were doing 32 ECMOs at a time. So you can see that this increase in the capacity buildup is mainly because of the increased demand. The function of the heart and the lungs is to maintain tissue and other organ perfusion. So if there is any problem with the right heart or the left heart or the lungs, tissue hypoxia results. And it is here that ECMO comes into place. ECMO is nothing but it's a circuit consisting of pump and an oxygenator and tubings. We drain blood from a major vein of the patient, passes through a pump and then to a membrane oxygenator where gaseous exchange takes place. Oxygen is given in, CO2 is driven out, and this oxygenated blood is given back to the patient. If we have to support the lungs, then it is given back to the large vein. Or if we have to support the circulation, that is the heart, then the blood is given back to the arterial system. So, what is ECMO if we have to define? It is the use of extracorporeal circulation and gaseous exchange. It provides temporary life support to patients with reversible and pulmonary and cardiac failure. So the terms extracorporeal circulation and gaseous exchange, these are important in ECMO. The goals of ECMO is primarily to maintain tissue oxygenation. ECMO is not a curative treatment. It is a supportive treatment. So you have to support the heart or the lungs till the primary organs improve. Till the time the heart or the lungs, which are vital organs of our body, till they recover, we can continue the life process. As well as we can give rest to these organs by coming down on the ventilator settings or coming down on the inotropic support to allow them to heal faster. So ECMO is a bridging therapy. It's a temporary therapy and a bridging therapy. as either a bridge to recovery, which is our primary target in most of the patients, or a bridge to decision. So we put the patient on ECMO, and then we have to wait for which direction the patient is going, or a bridge to transplant. So the patient is not improving, and we decide whether the patient is a candidate for transplant or not, so that the heart or the lungs can be replaced and the patient can have a healthy life afterwards. There are various phases for ECMO, starting from decision from ECMO in indicated patients to cannulation, initiation, maintenance, and weaning. We will discuss all of them in the later parts of the training program. So the indications of ECMO can be broadly covered into either a cardiac indication or a respiratory indications, or a combination of both. So if we have to support the circulation, if the patient is having a cardiogenic shock, it is a veno-arterial ECMO. If the patient needs lung support, then it is a veno-venous ECMO. If it is a combination of heart and lung problem, there can be a combination of the ECMOs, and we can have a VAV ECMO or other combinations as needed. But the basic thing of ECMO remains same. That is, we take out blood, deoxygenated blood from the patient, pass it through the pump and an oxygenator, and give it back to the patient. So prior to initiation of ECMO, we have to decide whether the patient has a likelihood of organ recovery or not. Some of the patients will have the organ may be damaged previously, and this acute event, after the acute event, the organ may not be likely to recover. So if the patient's organ recovery is not likelihood, then we usually avoid ECMO in these patients unless the patient is a candidate for heart or a lung transplant. Many patients with multi-organ dysfunction on high supports, with they are they have a poor outcome on ECMO. So our ECMO per se will not alter the outcome in these patients. So they are relative contraindications. Patients with disseminated malignancy or an advanced age. So a patient in an advanced age was previously considered as a contraindication for ECMO. Now, a patient with even patients more than 70 years of age are good, have better outcomes with ECMO, with the better care. Some of the patients really improve and go home. Other contraindications are severe cerebral injury or unwitnessed arrest, where the cerebral perfusion may not have been proper. So these are all relative contraindications for ECMO. So coming to the indications of ECMO, the event happening in the heart or the lungs has to be acute and life-threatening. It should be reversible, as well as you should have utilized all the conventional modes of treatment in these patients. And then you go for ECMO. So if the patient is unresponsive to conventional therapy, ECMO can be instituted. Coming to the indications, respiratory indications, it's primarily the respiratory failure because of ARDS, which can be maybe due to pneumonia, either viral or bacterial, severe status asthmaticus, chemical or inhalational pneumonia. They are all leading to ARDS and hypoxia. Trauma is another cause of ARDS. Some patients who are waiting for lung transplant get intubated, and if they are not maintaining, they are candidates for ECMO to maintain their life till we get a proper lung for support. In pediatric and neonatal age group, ECMO has been extensively used for hyaline membrane disease, for meconium aspiration syndrome, and congenital diaphragmatic hernia. Primarily, ECMO was previously mainly used for the neonatal and the pediatric age group, and the adults' utility has come up in the recent past. Various tropical diseases can lead to ARDS and are good indicators for ECMO. Before we jump to provide lung support, we have to decide how much is the lung is diseased. So the lung injury score has to be there. So to assess the lung injury, there are various scores or methods. So very common is the Mare score, which has 4 criteria, and there are points according to the criteria that has to be calculated. And the final score is the average of the 4 points. What are the factors we see? PF ratio. As the lung injury increases, the PF ratio decreases. The more the lung injury, the chest X-ray will be more pronouncedly uh, uh, having consolidation. More number of quadrants will be infiltrated. If you need a higher PEEP to maintain oxygenation, or the patient is having a very poor compliance, in these patients, the Mare score will be higher. So if the Mare score is more than 3, between 3 to 4, the patient is indicated for ECMO. Another criteria which can be easily calculated at bedside is the Eolia criteria that was used in the Eolia trials. So that has the oxygenation criteria as well as the CO2 criteria. The oxygenation criteria is the PF ratio of less than 50 for more than 3 hours, or less than 80 for more than 6 hours, despite the optimization of mechanical ventilation. So we optimize the mechanical ventilation, prone the patient, give medications, and still the patient's oxygenation is not improving. These are patients whom ECMO is indicated. And if the patient has a very tight lungs and the PCO2 is rising, and you cannot increase the ventilatory setup to a great extent, and the peak pressures and plateau pressures are increasing, there again we have to go for ECMO. So PaCO2 of more than 60 or a pH of less than 7.25, that is a respiratory acidosis, that is an indication for ECMO. The ELSO guidelines are also similar according to what we have studied so far. So we see that we have to consider ECMO as the PF ratio is decreasing. As the lungs becomes more tight, PF ratio is decreasing. We are going up on the FiO2 and the PEEP levels on the ventilator to maintain adequate oxygenation. There we have to think about ECMO. As the PF ratio is less than 150, we start discussing ECMO with the relatives. And if it is less than 100, then we go ahead for ECMO. Coming to the indications of VA ECMO, VA ECMO is utilized primarily for cardiogenic shock. Cardiogenic shock is low tissue perfusion because of low cardiac contractility and cardiac output. And the largest cause of cardiogenic shock is acute myocardial infarction. So in cardiogenic shock, the initial treatment with inotropes, inodilators, ventilation, diuretics, etc., all are given. As the inotropic support increases, there is a time when further increase in inotropic support will not be helpful. It is at that point that you have to decide to go for ECMO. Better early than late. Other indications being viral myocarditis in pediatric patients, post-cardiotomy, and post-CPB shock. They are very common indicators in the cardiac surgical scenario. Some patients present with calcium channel blocker, beta blocker, or cell-fast poisoning, very common in our setups. They come with a circulatory shock, and if they are supported for initial few days, these patients will improve. The cardiac function improves, and then we can wean off the VA ECMO. Some patients who are having chronic heart failure, but they have an acute problems. So there we can use ECMO as a bridge to LVAD or a bridge to transplant. Finally, eCPR is a very prominent indication of VA ECMO now. So where you have facilities, if it is a witnessed arrest, you give proper CPR for first 20 minutes, it is not improving, then we can put the patient on VA ECMO, maintain the circulation, normal circulation of the patient, that is maintaining the normal vital organ perfusion. Until the heart improves, you continue the VA ECMO and then we can wean off. So ECMO assisted CPR is an important indicator for uh, VA ECMO. Some patients who are going into brain death, and there the patients, if we have to retrieve the organs and if the patient is not maintaining circulation, there you can put the patient on ECMO and continue circulation till you retrieve the organs. So that is another indication of ECMO. There are various other methods of circulatory support. So the other mechanical circulatory assist devices, though present, are not as good as ECMO because ECMO has certain advantages. It supports both the ventricles, the right and left ventricle, both are supported. It provides oxygen to the body as well as it is quick and easy to institute. So all these advantages make VA ECMO a very good mechanical circulatory assist device. So if you ask me, sir, what is my job profile as a ECMO specialist, all of us, the our target is to provide oxygen to the tissues. Just as a Zomato delivery guy will give food to our homes, we give oxygen, deliver oxygen to the tissues. Thank you. Questions are welcome.